The next item of business is a debate on motion 4324 in the name of Shona Robertson on the Scottish Patient Safety Programme. I would invite all members who wish to speak in this debate to press their request to speak buttons now. And I call on Shona Robertson to speak to and move the motion.
Okay, thanks, Presiding Officer. I'm delighted to have the opportunity to share with you the many successful initiatives being rolled out to continue to improve patient safety in Scotland. And I want to thank all staff who are involved in this very, very important work. When we launched the Scottish Patient Safety Programme, it was ambitious and unique in the world. No country had ever decided to tackle patient safety head-on in this way. 8 years on, that is still true. We remain the only country in the world with the level of ambition that I'll describe today to strive for zero harm across our NHS and social care settings. Don Berwick, President Emeritus and Senior Fellow Institute for Healthcare Improvement, said recently, "What I love about what Scotland has done is it has done it scientifically. It has done it through developing the capabilities of the country to be a learning nation to actually improve things. That's how you've done brilliant work in patient safety." Our initial focus, understandably, was on acute hospitals with the aim to reduce mortality by the end of 2012. The work has expanded to include safety improvement programmes across 6 strands: adult hospitals, healthcare associated infections, maternity and children, medicines, mental health and primary care. This morning I visited the Public Dental Service Centre in Glenrothes, one of the practices participating in the Scottish Patient Safety in Dentistry pilot. The aim of the dentistry programme is to improve quality and safety in general dental practice through a collaborative approach. Dental teams now see many more patients who are on high-risk medications such as antiplatelet drugs or anticoagulants. For this reason, the work has focused on reducing the potential impact of dental treatment on this group of patients. And I'm delighted that Healthcare Improvement Scotland is further investing in dentistry, extending the testing phase and developing a plan to spread the learning. The expansion of work into dentistry, community pharmacy and nursing homes means that we have SPSP work in all healthcare settings, from our largest hospital in Glasgow displaying real-time safety data in each ward to small GP practices in Fife discussing patient safety at staff meetings. The Scottish Government's position on patient safety is clear. It is and will continue to be of paramount importance in the daily work in healthcare settings throughout Scotland. Today, the Care Quality Commission down south announced that there is a clear need for change in the NHS in England, including the need for safety to remain central, with many trusts failing to learn when things go wrong. And that's why Scotland's unique National Patient Safety Programme is internationally renowned and has made patient safety in Scotland the global benchmark for safe care. Since its launch in 2008, the SPSP has contributed to a significant reduction in harm and mortality through a national collaboration to improve the quality and safety of care. A number of factors have been key. We've built capacity and capability within clinical and non-clinical roles to develop and apply quality improvement methodology through testing of focused safety interventions to understand and deliver reliable evidence-based processes. We've used data to support improvement shared through national and local forums and networks. These data are on the walls in our healthcare facilities for all to see. We've tested and implemented leadership activities, providing strong organisational support for safety, such as executive safety walkarounds. Doing all of these things has helped create a culture within care that is more open, transparent, learns from success and failure, and continuously improves. And crucially, within that culture, individuals and teams have risen to the challenge and continually worked to improve safety. The programme has sought to engage frontline staff in improvement work by promoting the application of a common set of tested evidence-based interventions. This comes from a common improvement model based on the Institute for Healthcare Improvement model. However, we recognise that in order to meet the increasing demands being placed on our health service, we must reform as well as invest and work to accelerate the shifting balance of care. And that's why we've committed to introducing a national and regional workforce planning system across the NHS in Scotland. The national plan will look to strengthen and harmonise workforce planning practice, take full account of the future demand for safe and high-quality services for Scotland's people, accurately identify gaps in supply, and help deliver the vision set out in the National Clinical Strategy. The plan, which is currently being consulted upon and which will be published in the spring of this year, will take full account of the many demographic and other influences on our NHS workforce and enable us to continue to deliver a safe and sustainable NHS. We've also committed to enshrine safe staffing in law, placing the nursing and midwifery workforce planning tools on a statutory footing. The safe and effective staffing legislation work is progressing and the consultation period will begin in early spring of this year. A crucial element of the programme is that the changes are led by the staff who are directly involved in caring for patients. They can then monitor and see the improvements through the collection of real-time data at the individual unit or ward level. We know that many countries around the world, including Norway, Denmark, Sweden, Australia, Mexico, Chile and Tanzania, have looked at the Scottish model. They are keen to emulate what we have been able to achieve for the people of Scotland through the Scottish Patient Safety Programme, and many have begun to do so. Just this month, Singapore is visiting to learn from our approach. The Scottish Surgical Checklist introduced under the Safety Programme has been praised internationally by renowned experts such as Atul Gawande. This simple but powerful technique has been adopted across Scotland. It uses techniques developed in the airline industry to ensure that the safety of every surgical procedure is checked and assured every time. And we continue to strive to improve further. This week, the Chief Medical Officer's annual report was published, Realising Realistic Medicine. The report sets out an ambition to put the person receiving health and care at the centre of decision-making and encourages a personalised approach to their care. It aims to reduce harm and waste, tackle unwarranted variation in care, manage clinical risk and innovate to improve. And these are essential to a well-functioning and sustainable NHS. In response, Sir Muir Gray, who's the Director of the National Knowledge Service and the Chief Knowledge Officer to the NHS in England, tweeted, "NHS Scotland is the future of healthcare." So good praise indeed, and we'll take that. Patient safety goes beyond the programme itself. Our Diabetes Improvement Plan includes actions to improve the quality of care of people living with diabetes who are admitted to non-diabetes wards in hospital by improving their glucose management and reducing the risks of complications such as foot ulcers. Only this week, we've written to the Chief Execs of NHS boards to begin the national adoption of 2 important diabetes initiatives. To support this, the Scottish Government will fund 1,000 hypo boxes to be made available in acute wards across Scotland. This will ensure a standardised and improved approach to the management of low blood glucose and will improve patient care. I think it's important to share with you some of the specific improvements that have been achieved across the country. The primary care programme launched in March 2013 has been successful in improving the care delivered by health and social care partnerships. This includes general and dental practices, community pharmacies and care homes. One programme's aim was for 95% of primary care clinical teams to be developing their safety culture and achieving reliability in 3 high-risk areas by 2016. Also, if we look at the mental health programme, increasing number of wards and units are showing improvements. This includes a 78% reduction in violence, a 57% reduction in the use of restraint, and 70% reduction in self-harming. Speaking about the identification of physical conditions for people in Scotland with mental illness, Francis Simpson, the Chief Executive Officer Support in Mind Scotland, said recently, "Among the most supportive has been the Scottish Patient Safety Programme team, whose staff have opened up access to hundreds of health professionals across the country for the Equally Fit message." Yes, of course.
Elaine Smith.
I thank the Cabinet Secretary for taking that intervention. In terms of maternity and children, Cabinet Secretary, in Forth Valley Royal Hospital at Ladbert, it was recently revealed that stillbirths were disproportionately higher than national average, but those deaths don't seem to be counted in the mortality rates according to the National Records of Scotland. I wonder if you could make any comment on that.
Cabinet Secretary.
What I can say to Elaine Smith is that there has been an 18% reduction in stillbirths, and a lot of that work is due to the Patient Safety Programme, working with frontline professionals in changing some of the practices. But there's more work to be done, and that's why, of course, we've just had the review of maternity and neonatal services, which makes a number of recommendations that we will be taking forward to further improve that. But I think we should recognise that that has been a significant improvement, but there's more work to be done. I just want to turn briefly to the medicines programme, which aims to bring together improvement activity related to medicines from acute care, primary care, maternity and children's service and mental health, providing a unique opportunity to consider the safer use of medicines from a whole system approach, focusing on the patient as they move between care settings and home. The first key areas of focus for the programme is medicine reconciliation. This focuses on reducing harm from medicines across transitions of care by ensuring medication is accurately checked and prescribed. And finally, I'm delighted to report that the hospital standardised mortality ratio, which provides details of unexpected hospital deaths, continues to decrease. As this was the primary aim of the programme, the continued reduction in these figures is a real success that I'm proud to celebrate. The latest available hospital standardised mortality ratio figure published last month indicates that this has reduced nationally by 8.6% since 2014, and this is well on track to reduce further to 10% by December 2018. Similarly, national data published at the end of 2016 indicates that there has been a 24% reduction in surgical mortality, a 21% reduction in sepsis mortality, an 18% reduction in stillbirths, as I mentioned earlier, a 93% reduction in healthcare-associated infections, and a 78% reduction in ventilator-associated pneumonia rates. Now, I recognise the very significant challenges facing our health and social care system in terms of our ageing population and the increasing numbers of people living with multiple and complex conditions. For that reason, we need to maintain momentum and continue to improve quality of care. We must apply our successful improvement approaches to allow us to continue to deliver today and into the future better outcomes for the Scottish people. I move the motion in my name.
Thank you, Cabinet Secretary. I'm going to call on Donald Cameron to open for the Conservatives to move the motion, the amendment 4324.1 in his name. Just to let all members know, there's plenty of time. Members may take their time over the remarks this afternoon. Mr. Cameron.
Thank you, Presiding Officer. I'm delighted to open this debate for the Scottish Conservatives because it is a clearly very important one to have, and I'm pleased we are finally having it since it originally appeared on the Business Bulletin several weeks ago. As I've said many times in this chamber, on issues across health and beyond, these benches will act as a strong opposition, scrutinising the actions of this government at all times. We will critique the government when we feel it is not performing to standards expected by the people of Scotland, but similarly, we will welcome positive achievements that make a real and tangible difference to people's lives. And with that spirit in mind, we on this side of the chamber fully support the Scottish Patient Safety Programme, its aims and objectives, and we will continue to support it as its remit grows. That means ensuring that every Scottish citizen who enters a hospital, whether that be for an outpatient appointment, for minor treatment or for a longer stay, should all have a right to outstanding treatment, professional care, and above all else, know that they are safe from further illness or complication where it can be prevented. The need for every patient in our health service to be safe is obvious and paramount. But context is important in understanding why the Scottish Patient Safety Programme came into being in the first place. Before it was introduced, it was recognised that hospital deaths were too high and that the number of people succumbing to infections or other complications was excessive. In fact, the Scottish Patient Safety Programme acknowledged that there are many severe risks which exist in Scotland's hospitals. In 2008, it was estimated that around 2,000 falls occurred in Scottish acute hospitals every month, accounting for a third of all reported patient safety events. In 2011, NHS statistics showed that around 22% of all healthcare-acquired infections were urinary tract infections, with 4% of patients developing life-threatening bacteremia or sepsis as a result. These statistics range over different timelines and different conditions, but all highlight that there are always risks in hospitals, proving the need for a monitoring body to ensure that these can be reduced as much as possible. And given the original aims of the Scottish Patient Safety Programme when it was first established to oversee reductions in infections, life-threatening developments and sadly deaths in acute hospitals, there have been many successes which must be welcomed, and I am happy to welcome. Since 2007, there has been a 16.5% reduction in hospitals' standardised mortality ratios, and it is good that the up-to-date information the Cabinet Secretary just provided confirms that it's ongoing. But in plain English, there are now fewer avoidable deaths in Scotland's hospitals, which is testament to the hard work and commitment of our NHS staff, and we should all welcome that. The remit of the programme has indeed expanded over the last 10 years to include the monitoring of healthcare-associated infection, maternity and neonatal services, safer use of medicines, mental health services and primary care services. And on primary care, there have been many notable achievements, including the fact that 93% of all GP practices now regularly participate in the Scottish Patient Safety Programme's Safety Climate Survey. And this allows practices to monitor performance against other practices, allowing patient safety to develop within a practice and to check not just safety within a practice, but the perception of safety within a practice. I will talk briefly on maternity services, as I know other colleagues will elaborate further on this area. But since 2007, it is notable that stillbirth rates have fallen. There are a lot of achievements to praise, and I can't stress enough that we on these benches, and indeed everyone across this chamber, I'm sure, supports our NHS frontline staff and the phenomenal work that they carry out in keeping patients safe in ever-changing and difficult circumstances. But it is also right that we talk about what we need to do better in order to ensure the aims of the programme are fully met and continue to be met. And whilst many of the overall statistics are delivering better outcomes for patients, there remain inconsistencies in the performance of individual hospitals. My own local hospital, the Belford in Fort William, had significantly higher mortality rates than the national average in the first quarter of 2016. Dr. Gray's Hospital, the Inverclyde Royal, the Royal Alexandra, the Vale of Leven were all recorded as being above the upper warning limit for these ratios in the most recently available information. And the Cabinet Secretary mentioned the Chief Medical Officer's report this week. In that report, she also noted that the Chief Medical Officer also noted that between 2011 and 2015, E. coli, for example, has risen by 5.2% year on year, and that half of the near 4,600 cases of E. coli in 2015 were associated with healthcare. So public confidence is important, and that remains an issue. As last year's inpatient experience survey notes, 1 in 5 people say that they had experienced problems during their hospital stay, and nearly a quarter of people felt that their condition worsened while they were in hospital. So it's clear that while much progress has been made on patient safety, there is still a lot to do. And any debate on patient safety must consider current levels of NHS staffing, and it is here that I have to adopt a more critical tone. It is no coincidence that every opposition amendment today mentions staffing. Those amendments were lodged without any collaboration. Across the chamber, there are clearly huge concerns around this. We need to ensure that the great work being carried out by NHS staff is supported and aided by ensuring that the NHS has the right number of frontline staff to deliver these changes. NHS staff can't be expected to achieve and deliver a Scottish patient safety programme and its targets when there are so many unfilled vacancies across the board. And we have been consistent in our calls for a solution to this crisis and have highlighted it time and time again. And that is why we have lodged our amendment to the motion. The terms of the government motion are entirely laudable, but given the crisis in staffing, we cannot simply leave matters as they stand. It is only realistic to expect progress. Yes, indeed.
Claire Hockey.
I thank the member for taking that intervention.
Right, Claire Hockey, microphone for Claire Hockey.
Thank you. I thank the member for taking that intervention. Would the member accept that the NHS staffing rates are at the highest that they have ever been, and that this government has increased staffing rates across all of the staffing groups in the NHS?
Donald Cameron.
Well, I've said many times, and thank Claire Hockey for her intervention, I've said many times it is not enough, and the professional bodies say this too, it is not enough simply to say we have got record numbers of staff. There are record numbers of people getting old in Scotland, and we need sufficient numbers. These aren't just the cries from opposition parties. Some of the major professional bodies have voiced real concerns. BMA Scotland said that staff shortages could lead to a system breakdown and that the NHS is being stretched pretty much to breaking point. The Royal College of Midwives say that due to higher birth rates and a lack of recruitment, Scotland's maternity services are beginning to buckle. The Royal College of Radiologists said that Scottish radiology is on the brink of collapse. And crucially, they say that patient safety is at risk. So, Deputy Presiding Officer, we welcome and acknowledge the work being carried out by the Scottish Patient Safety Programme to uplift standards and share best practice. We recognise and we support our NHS staff as they work to implement the changes required to ensure all of Scotland's patients receive quality care. But we also believe that in order for these results to continue to improve and come to fruition, the government must commit to ensuring that staff vacancies are filled so that these expectations can become a reality. I move the amendment in my name.
Thank you. And I call on Anas Sarwar to open for the Labour Party and to move amendment 4324.2.
Thank you, Presiding Officer. Can I start by thanking the Cabinet Secretary for bringing this debate forward and to say we will be supporting the government motion today. I think there is a lot to welcome in terms of the Scottish Patient Safety Programme, what it has delivered for Scotland. And on that, I think we should pay tribute to all the staff and the management who have helped deliver the Patient Safety Programme and thank them for the work they are doing on the front line to actually support people in our National Health Service. Like Donald Cameron, I welcome the improvements in the mortality rates, the reduction in hospital deaths, and also the very welcome reduction in hospital-acquired infections, all things that I'm sure everyone right across this chamber will want to welcome. I will come in a moment to talk about some other challenges which I think are also associated around patient safety, but I do want to once again take the opportunity to thank not just all those staff members that are involved in the Patient Safety Programme, but actually our NHS staff right across the National Health Service who go above and beyond to deliver care for people right around the clock all year round, whether that be in primary care, whether that be in acute care and social care, or specific services around maternity services or mental health. So a genuine thank you to each and every single one of them. I do have to reflect, though, Deputy Presiding Officer, that we have had a lot of challenges around the National Health Service since this parliamentary term began. There are still some severe issues around, obviously, the decisions that the Cabinet Secretary has made, the mismanagement of the NHS in many ways that has left our NHS staff overworked, undervalued and under-resourced. And while I again say I welcome the motion and we will always support the motion, I do think the Cabinet Secretary shouldn't simply be patting herself on the back, but also should look at the genuine challenges that we face. I welcome the fact that we finally have a meaningful debate on the NHS in government time, but I would also hope that we could have a meaningful debate on the new health and social care delivery plan, which is a strategic approach for the NHS for years to come, or a meaningful debate on access to new medicines, or a meaningful debate on the maternity and neonatal review, or a meaningful debate on what's happening in our social care sector, where we see continued cuts to local government budgets and meaning local cuts to social care budgets too. And I listened to the Cabinet Secretary mention service reform, and I also read with interest the Cabinet Secretary's comments in Holyrood magazine in relation to service reform. And I quote, "I have had opposition members sitting in that very chair that you're sitting in, and I put these issues to them, and they'll sit in here and agree with me, but on the floor of Parliament, you get into a different territory, and they'll say something entirely different." That is simply not true. Shona Robertson is 100% wrong, and she perhaps inadvertently, but I suspect not, is trying to mislead people about service cuts. Because not once has the Cabinet Secretary met with me or any of my front bench colleagues, I can't speak for any other parties, in private to outline specific service changes she proposes, and not once has she had the courage to come to this Parliament and make the case for the specific service reforms she proposes. The only debate that we have had on service reforms have been in opposition time, in which the Cabinet Secretary attempted to deny that any service reforms even existed, and on that day she even lost the vote too. So why doesn't the Cabinet Secretary be brave enough to come to this Parliament in future and make the case for the service reforms she supports, rather than simply hiding behind the health boards. But there are wider issues here too that also impact on patient safety, Deputy Presiding Officer. It is very clear the resource is not meeting demand. How is that going to improve patient safety? Because across Scotland, health boards are being held accountable for delivering improvements in healthcare and improving patient outcomes, but they're also having to make cuts year after year, forced upon them by this Cabinet Secretary. Cuts of more than £1 billion in the next 4 years. £1 billion of cuts. How's that going to improve patient safety? Happily.
Bruce Crawford.
Well, for the member given way, with all due respect to Anas Sarwar, I'm sure he would accept that even the Tories in their manifesto for the election in May promised more for the health service than the Labour Party did. And therefore, instead of making all these chuntering noises about spending, if you could come up to the plate with real money from the Labour Party, that would help everybody in that regard. And if every single thing that the Cabinet Secretary would suggest wasn't opposed by people and by way of reform, that would also help the process.
Anas Sarwar.
I thank Bruce Crawford for that intervention. I think perhaps as the chair of the Finance Committee, he perhaps should have read Labour's budget amendment, which talked about how we use the tax powers of this Parliament to actually invest more in our NHS, but also to use the tax powers to stop the cuts to local government, meaning cuts to social care, which also impact directly on the NHS. All I'll gently say to the SNP benches is, you can repeat a line as often as you like, it does not make it true. The reality is there are cuts happening across health boards under this government. And we've also seen a complete failure to workforce plan, with vacancies right across the NHS. More than 2,500 nursing and midwifery vacancies, including mental health nurses. It means that only a third of NHS staff feel there are enough of them to do their job properly, and 9 out of 10 nurses say that the workload is getting worse. How's that going to improve patient safety? And in primary care, we have 1 in 4 of Scotland's GP practices reporting a vacancy, asking staff to do more while they oversee the worst workforce crisis since devolution, leading to the chair of the BMA to warn that it will lead to personal breakdown and then system breakdown. How's that going to improve patient safety? We have cuts to local services across the country, with maternity wards, a paediatric ward and intensive care neonatal units under threat. How's that going to improve patient safety? We've had the worst Audit Scotland report since devolution, with 7 out of 8, let me just finish this point, with 7 out of 8 patient standards failed, including A&E, cancer treatment and mental health. 7 out of 8 standards failed. How's that going to improve patient safety?
Shona Robson.
Back to the neonatal report. That report was a report of experts, including input from Bliss, and actually very much led by patient safety. Is Anas Sarwar saying that that report is wrong and he knows better than the experts who have recommended those changes? Just for clarity.
Absolutely not. I welcome the Bliss Scotland report, but actually if you look at the findings in Bliss Scotland report, that is not a record to be proud of, Cabinet Secretary. That is a record to be ashamed of, because they talk about 3/4 of units not having enough nurses or staff to meet minimum standards. And the Cabinet Secretary wants to congratulate herself on the fact that 3/4 of units don't meet minimum standards. Again, how's that going to improve patient safety? And we've seen continued cuts to social care budgets, meaning we've got chronic problems with delayed discharge, over 500,000 bed days lost in 1 year alone, with patients trapped waiting to go home. I asked the Cabinet Secretary, how's that going to improve patient safety? And we have Audit Scotland, again in a separate report, saying that now the spiralling costs of private agency spent means we're now up to £175 million a year. And they quote, agency staff are likely to be more expensive than bank nurses and also pose a greater potential risk to patient safety and the quality of care. That's Audit Scotland saying that, not me. How's that going to improve patient safety? And, Presiding Officer, I explored the Patient Safety Programme webpage, and I found a really interesting article in that webpage which actually referred to a meeting of senior NHS managers in Greater Glasgow and Clyde. And they posed 3 questions at this meeting. Remember, this was part of the Patient Safety Programme. The first one, why is the largest health board in Scotland in persistent financial over-parity despite extensive efforts to overcome this via efficiency savings. Over-parity, that's civil service speak. Secondly, they asked, how will it be able to squeeze into a smaller bed complement with the new hospital on the south side when demand is exceeding supply? Third, they asked, why is the compliance with 4-hour accident emergency waiting time the worst in Scotland and deteriorating? These are all serious questions. So in closing, Deputy Presiding Officer, I say to the Cabinet Secretary, if she really wants to improve patient safety, get her head out the sand, address the workforce crisis, stop the cuts to local services, stop the cuts to NHS boards, and actually meet patient standards across the country. I formally move the amendment in my name.
I call Alex Cole-Hamilton to speak to and move Amendment 4324.3. You can have a little extra time, Mr Cole-Hamilton.
Well, thank you very much, Deputy Presiding Officer. The Scottish Liberal Democrats are absolutely happy to welcome this debate today, and we will be supporting the government motion and all opposition amendments. As a platform that aims to improve safety and harm reduction in any landscape where care is delivered, then the Patient Safety Programme sets an international standard. It successfully delineates an approach to safety from birth through to death and at every stage and transaction in the delivery of health and social care in our society. And I welcome the opportunity afforded in this debate to scrutinise its merits in granular detail. The welfare and safety of our citizenry must always be the alpha and the omega of our responsibility as legislators, and the delivery of health and social care represents the largest such landscape in which we must, as public servants, discharge that duty. Since its inception, the Safety Programme has delivered groundbreaking interventions and the dissemination of best practice at every level of care in our society. From the prevention of sepsis, as we've heard, providing a whole systems approach to infection control, and underpinned by robust data analysis, which is building a structured approach to all frontiers of patient safety. In a press release, the programme released in early 2015, it stated, the Patient Safety Programme patient safety problems exist throughout the NHS, as in all large, complex healthcare systems in the world. However, it is not staff negligence, but the systems, procedures, environment and constraints faced by healthcare professionals that lie at the root of most safety problems. Presiding Officer, I think all of us share the sentiment that our health and social care staff represent some of the finest professionals in Scottish society, but a structural problem exists that can run contrary to the efforts of the Patient Safety Programme, that visits symptoms on every aspect of our health service, and that in turn impacts on the work of the Patient Safety Programme. Problems in workforce planning create a blockage that impedes patient flow through primary, acute and ultimately social care at every stage in the health journey. A shortage of GPs, and we know that at the end of this decade we could have nearly 1,000 fewer GPs than our society will require, creates appointment delays, which in turn can see conditions become more acute and result in hospital admissions where early intervention could otherwise have been prevented. This, in turn, exerts upward pressure that manifests in every other part of the health service, and coupled with the postcode lottery that is around the availability of adequate social care packages, this can lead to delays in hospital discharge, which we've heard from Anas Sarwar, on a monumental scale. Recent volley of freedom of information requests issued by my office discovered the extent to where patients, in some cases, are staying in hospital for as many as 500 days beyond the point at which they are declared fit to go home. Absolutely, I take
Shona Robson.
Hopefully Alex Cole-Hamilton, I think, was copied into the letter I sent to Willie Rennie on that subject, because the cases that were highlighted, many of them were very, very complex cases where they were, for example, waiting for a house to be built, or some very, very specific packages, and people who, weren't readily able to be discharged from hospital. Would Alex Cole-Hamilton recognise these very, very complex cases that he's referring to?
Alex Cole-Hamilton.
Well, I thank the Cabinet Secretary for her intervention. I'm delighted she raises this, because actually, when I raised it at FMQs, we didn't get to cover the fact that our specific FOI requested information on people who are left in hospital beyond the point at which they're declared fit to go home, entirely because of the social care package being unavailable, not because of houses being built, not because of very specific secure care needs. So I'm really glad that we've got the opportunity to thrash that out. I'd like to return to a more consensual tone. But this does present this really does present an immediate challenge for patient safety programmers, because we know that prolonged stays in hospital increase patient exposure to things like pressure sores and hospital-acquired infection, even though we have heard how well we are doing in reducing that. Put simply, Presiding Officer, if we can get the workforce planning right, by extension, delayed discharge, we can take a giant leap forward in improving patient safety. And I welcome the steps outlined by the Cabinet Secretary towards a plan in terms of workforce planning. But the locus of the programme rightly extends beyond the traditional institutions in which health and social care are delivered. With the advent of new initiatives such as Hospital at Home and the decades-old approach to care in the community, we must turn also to ensure that patients are kept safe in any setting where they receive care. First and foremost, this must follow a proactive, preventative approach where we can anticipate and mitigate risk from any outset. In December, I had the great honour to chair the Older People Forum in this chamber. It was a fantastic event, a very robust, vibrant exchange of views. In one session, I asked everyone assembled about what they were most worried, what was the thing that they were most concerned about. And I was very surprised to learn that fear of falling outstripped crime, loneliness and money worries against everyone present. And given the commonality of falls and the direct causal link between falls and senior mortality, there is a great desire among older citizens for us policymakers to take action. And that is why, Presiding Officer, I'm today calling for the Scottish Government to develop a national falls strategy, building on the work of the fall prevention framework of 2014. This should include, I'd like to make some progress, please, Emma. Presiding Officer. Ms. Harper, thank you. But this would include comprehensive training for all care staff, the employment of technology, a full suite of marketing and awareness raising materials to help older people stay safer in their own homes or in any setting in which they receive care. Put simply, fall prevention is one of the most important steps we can take in promoting patient safety. Final area I'd like to cover, Presiding Officer, is around mental health, and the mental health specifically in the work of the programme. Its inclusion is of course welcome, but it stands alone as a separate thread, and to my mind that standalone nature undermines the fact that it has a causal relationship with every aspect of patient safety. It is right that we should focus on physical safety, but there has to be an element of mental safety for our patients as well. At the moment, the patient safety programme focuses on restraint and seclusion and an understanding of risk factors, but it should also focus on prevention of mental ill health as well as a vital aspect of improving patient safety. In its work around safety in maternity, for example, it should look to the dissemination of best practice and roll out perinatal specialists and perinatal mental health specialist support teams across all of our health boards and share that knowledge. After all, 1 in 5 mothers will experience mental ill health as a result of pregnancy, and yet only 5 health boards have dedicated perinatal mental health teams. Similarly, in some cases where mental ill health strategy is a factor in patient care, any risk assessment around patient safety must include the likelihood of self-harm or suicide prevention. I'm coming to a close now. This is why it's so fundamentally important that the safety programme dovetail with a nascent mental health strategy and the successor to the suicide prevention strategy. Presiding Officer, we must be justifiably proud of this. This is an international standard, as I have said, and we should be proud of this patient safety programme, which is groundbreaking in so many ways. And I certainly come to this chamber not to bury it, but to praise it and to see it enhanced, and therefore I move the amendment in my name. Thank you.
We now move to the open debate. Speeches of 4 minutes, please. First of all, Emma Harper, to be followed by Brian Whittle.
Thank you, Presiding Officer. 20 years ago, I was involved in the improvement of safety in the perioperative environment in the United States. It was a collaborative approach with the USA's Institute for Healthcare Improvement. For example, I taught best practice and standardised approach for surgical counts of swabs, needles and instruments so that retaining or losing a surgical instrument inside an abdomen could be avoided. There is a growing implementation of non-technical skills to safeguard patients as well, and that was adopted and promoted in the USA as well as here in Scotland. Situation awareness, good decision making, flattened hierarchy, leadership and a good approach to teamwork and communication. So in Scotland, this research has been procured and then continued by Professor Stephen Yule and others at the IPRC in Aberdeen. And as a clinical educator for NHS Dumfries and Galloway, the training programmes that were initiated by myself and my colleagues for healthcare support workers and nurses had a specific focus on safe, effective, person-centred care. I collaborated with colleagues regarding verbal handover from the anaesthetist to the post-anaesthesia recovery room nurses so that clear plans of care were identified and documented. And I provided education about deep venous thrombosis prophylaxis and prevention of central venous access line infections and medication safety, so that the right patient, the right drug, dose, route and time are achieved for improving our safety of our patients. Quick, snappy education sessions were also delivered using the 1-minute education approach, and we used that for sepsis 6 as being only one of the items we educated on. I could continue to give more examples of these seemingly small but immensely important measures which can make a difference between life or death. They are vital to the improvement of both acute and primary patient care. So I'm pleased to be able to speak in today's debate, not at least as it enables me to say to this Parliament that my former colleagues in the NHS Dumfries and Galloway and across NHS Scotland deserve to be commended and congratulated for their ongoing work to promote best practice using evidence-based care. Too often we hear nothing but negativity surrounding our NHS, and I can tell you today that this has a very real effect on the morale of nurses and doctors. I was very proud that Scotland, the first country in the world to launch a national patient safety programme, it happened in 2008. The programme has been vital to delivering the highest quality healthcare services to the people of Scotland and is recognised as world-leading in the quality of healthcare it provides. In fact, Barack Obama mentioned Scotland as one of the best health systems in the world when he was president. Since its launch, the acute adult programme has contributed to a significant reduction in harm and mortality to adult patients through measures such as those I described above and many more. Since 2008, the scale and ambition of the programme has grown, and the work which began in acute adult hospitals now extends to primary care, mental health and maternal and child health. There are many examples of cultural change brought about by the programme, notably in mental health settings where we have seen a real shift in the approach taken to the administration of psychotropic medication and improvements in how challenging behaviour is managed. The SPSP will be a service that continually adapts to meet our changing needs, embraces new technologies and approaches to care. We should be proud that, thanks to its implementation in Scotland, it plays a leading role in patient safety initiatives in Europe. NHS England officials have praised the programme, stating that they hope to use the experiences and learning to take forward in England. According to Mr. Mark Wittenberg, a clinical fellow at NHS England, the programme is unrivalled and contains much that should be replicated in England. So, Presiding Officer, the figures of 8.6% reduction in hospital standardised mortality, coupled with the praise from bodies such as the OECD and NHS England, show exactly why our Scottish Patient Safety Programme deserves its international reputation as a world leader. Thank you.
I call Brian Whittle to be followed by Fulton McGregor.
Thank you, Deputy Presiding Officer, and I refer to my declaration of previous business interests, and also that I have a daughter who is an NHS midwife. Now, I welcome the chance to speak in this debate on the Scottish Patient Safety Programme and the excellent work our healthcare professionals do in ensuring the quality of care and the safety of patients is of the very highest standard. Whilst we recognise the significance of the Scottish Safety Programme, I think it is always incumbent upon the interested parties to continually examine the programme and look for ways to improve it and enhance it, and that includes in this chamber. In the short time I have, I would, if I may, look to make 2 points. Firstly, I would like to highlight that in delivering the Patient Safety Programme, it is essential that we recognise that a key element in its effectiveness is the safety, health and well-being of the NH staff themselves. And we do have to recognise that the system is under quite a bit of stress, which has a detrimental effect on those who are working within that system. For example, with Ayrshire and Arran Health Board, there is a consistently higher than average absentee rate in the neonatal and midwifery section, sometimes more than double the national average, and this has been the situation for at least the last 5 years. This, of course, to me represents a department that is under quite a bit of pressure. Furthermore, we know that there is a growing issue of losing experience from the profession, with some 1,200 midwives in Scotland over the age of 50 who are eligible for retirement at 55. This experience cannot be replaced by newly qualified staff, which, if not addressed, could put staff in situations in which they have no experience and, crucially, without the support of more experienced staff. This has to speak to a heightened risk to patients, especially in emergency cases. Now, I know that the Royal College of Midwives recognise this and are attempting to recruit experience from outside of Scotland. Indeed, the last time I spoke to the head of the Royal College of Midwifery a couple of weeks ago, she was at an event in London where they were actively promoting Scotland as a career destination. There is a general recognition that the new neonatal strategy announced by the Cabinet Secretary last week is a step in a positive direction. However, if the workforce does not have enough capacity to deliver the strategy, once again the safety of patients will be brought into question. See, midwives want to get away from what the RMC describe as conveyor belt care and into a more personal care where they can effectively address preventable health issues. This leads me to the second point I would like to make, and that when things do go wrong, it is crucial that NHS boards are in learning mode and are able to scrutinise system failures as well as where clinical issues arise to ensure and enhance future patient safety. However, there is no national standardised process describing what constitutes a significant adverse event, with the NHS Trust reporting significant adverse events in widely varying numbers. What's more, when Health Improvement Scotland review cases, it seems they do so under the instruction from the Scottish Government, and where they do, they can only offer recommendations. There is no regulatory powers apart from in the private sector. We need to consider if these recommendations are implemented, how we audit the implementations, and how it is further reviewed. So in conclusion, Presiding Officer, in highlighting the importance of patient safety, we should recognise that the safety and working environment of our HCPs is crucial. Staff numbers are inevitably linked to the health and well-being of NHS workers and therefore speaks to the safety of patients. When considering patient safety, it is important that a national system for triggering a significant adverse event investigation is in place and allows for a consistent response that staff and patients feel comfortable engaging with and giving feedback to. Furthermore, any recommendations made by any review must be rigorously implemented and reviewed to ensure consistent learning continues to enhance the patient safety programme. Thank you.
Fulton McGregor, to be followed by Elaine Smith.
Thank you, Presiding Officer. I'm pleased to speak in this debate, and I will take the opportunity to remind the Chamber that I am the Parliamentary Liaison Officer to the Health Secretary. As has already been alluded to, the hospital standardised mortality ratios for Scotland has decreased by 16.5% between 2007 and 2015. And now the latest published figures show that there has been a 8.6% reduction in hospital standardised mortality ratios in Scotland's hospitals since the baseline figure from 2014. Not only this, but a total of 10 hospitals have shown a reduction in excess of 20%, including Monklands Hospital, which serves my constituency. Now, I've actually got a personal story here. In January 2000, my gran was admitted to Monklands Hospital and sadly passed away there after contracting pneumonia. And although she would want me to point out that the care that she received was tremendous, and there's definitely no fault in terms of the staff at the hospital, it is heartening that statistics such as these, which inevitably she is one of, are decreasing over more recent years, and Monklands Hospital over the last decade has regained its good name. So it's absolutely shocked me over the last few weeks, including First Minister's questions last week from members of the Labour Party, calling the saving of the A&Es across Scotland, including the one at Monklands, a 10-year-old story that doesn't want to be heard. This is something that's actually been niggling at me for quite a wee while, because I beg to differ with that, and I expect the thousands of patients whose lives have been saved also disagree. I want to put on record today that Monklands A&E is a vital service for my community, and the fact that it was saved 10, 20 or when it's 30 years should not simply be dismissed. Yes.
Elaine Smith.
Thank Fulton McGregor for taking that intervention, but would he state just now on the record that the A&E at Monklands is fully and properly staffed at the moment?
I thank
Fulton McGregor.
Oh, sorry, thanks. Thank Elaine Smith for her intervention. It is my belief that it is fully and properly staffed and I thank the member for that intervention. Presiding Officer, despite the significant challenges of Scotland's public health record, Scotland's changing demography and the economic environment, the Scottish Government has set out a strategic vision for achieving sustainable quality in the delivery of healthcare services across Scotland. The 2020 vision that this Government has set out delivers the necessary strategic narrative and context for taking forward the implementation of the quality strategy and the required actions to improve efficiency and achieve financial sustainability. I welcome the Scottish Government's 2020 vision, where everyone is able to live longer and healthier lives, and ensure that we have a healthcare system where health and social care go together, hand in hand, and we continue to focus on prevention, anticipation and supported self-management. I think it is critical to continue in pursuing the goal of providing the highest standards of quality and safety, regardless of the setting, with the patient at the centre of all decisions. And I think it's therefore important that all forums of support across our communities are nurtured. On Monday of this week, I visited the Coatbridge meeting of Lanarkshire's Carers Group, and I heard there first-hand from all the carers about how much they valued that service and how worried they are about the pending cuts from North Lanarkshire Council, and how that might impact how they care for their relatives. So I think that it's imperative that we support across the board. And I've also had contact with the St Andrews MS group, where the chairperson is a member of my constituency, and they're also at present fighting for an increase in the number of specialist MS nurses across North Lanarkshire, and I've submitted a question to the Cabinet Secretary to that effect. But that's yet another example of how we can support other groups that are trying to support themselves in this area. As we have also heard, a key part of this debate has been that the SNP government has enshrined safe staffing in law, and the consultation period will begin early in spring. The link between safe and sustainable staffing levels and high quality care is well established. It is vital to have the right number of staff in place, as others have said, with the right skills, and I really welcome Emma Harper's contribution to the debate in bringing in her experience with that. Scotland has led the UK in the development of nursing and midwifery, for example, and the implementation of workforce planning tools. Presiding Officer, progress has been made, but with changing demographics and in the face of Tory cuts, we must continue to work together and be innovative across all health services, so that those that serve my community and all others across Scotland are the best that they can be. Thank you very much.
I call Elaine Smith to be followed by Marie Todd.
Thank you, Presiding Officer. Naib Evans said, illness is neither an indulgence for which people have to pay, nor an offence for which they should be penalised, but a misfortune, the cost of which should be shared by the community. And that was why Labour created our NHS, and it remains one of people's most valued assets right across Britain. However, people expect it to be safe when using it, and so whilst this unique plan is welcome, we must consider it closely and we must strive always for improvement. It's important to make clear at the start that our hard-working NHS staff deserve our thanks for all they do, but they are under extreme pressure. And the use of agency staff has increased, with spending rocketing in the past 4 years, despite Audit Scotland warning that, and I quote, agency staff are likely to be more expensive than bank nurses and also pose a greater potential risk to patient safety and quality of care. I'm sure we can all agree in the debate this afternoon that improving our hospitals and keeping staff well trained and at safe levels takes investment and long-term planning, and is something we would all want to see. Presiding Officer, under the plan, safer use of medicines is a worthy goal, but it isn't well served by not providing people with correct medicines in the first place. And the Cabinet Secretary has mentioned that on Monday, Scotland's Chief Medical Officer, Dr Catherine Calderwood, said that doctors should spend more time listening to their patients to avoid unnecessary treatments. And Dr Calderwood calls this realistic medicine, focusing on quality of life, not efficiency of treatments. But it's not realistic for some patients if they can't actually get the medicine they need to live a normal life. And I want to give an example of thyroid patients here, who are mainly women. Far too many are not being properly diagnosed, they're being refused access to liothyronine, and they're forced into buying desiccated thyroid hormone over the internet. And that is hardly safe, and it is not putting patients at the heart of their own care. And it's also common for some thyroid patients to be prescribed antidepressants, perhaps because their GPs do not have the time to listen to their patients and therefore cannot reach a proper, safe and correct diagnosis. So this is an example where patients with chronic, disabling and life-threatening conditions are being deprived of treatment due to cost or close-mindedness on behalf of the medical establishment and NHS boards, as well as GPs being under immense strain. And it's something that I think should be considered further, and the Petitions Committee of this Parliament is actually considering it at the moment. Getting patients in and out of hospital safely and for the right amount of time is a key concern for patient safety. Labour obtained official figures back in January which showed that 683 people died in hospital between the start of March 2015 and the end of September 2016 after being deemed medically fit to leave. And yet, of course, we have promises to end the practice of bed blocking. But even getting into hospital at the moment for desperately needed operations is a problem. In NHS Lanarkshire, there's an up to 24-week wait for an initial appointment for a hip replacement. Now, that's 24 weeks in extreme pain for older people who will then have another long wait for the actual operation. And that is despite the government giving a 12-week guarantee, although I accept it's not a legally binding one. And then what happens afterwards? Well, I know that the figures may show a decrease, but I am becoming increasingly concerned about people that I'm hearing about with acquired infections. And I think that's something that may need looked at. But I'm also concerned about those that tell me that aftercare is poor, and that seems to be due to staff shortages and, yes, in some cases, to low morale. And actually, a recent story which was quite disturbing was of a constituent who waited 30 minutes pressing her buzzer and then had to suffer the indignity of having to wait herself. Now, I think it's also important to consider the kind of people dying in our hospitals and why and how we might be able to prevent that. We know, for example, that Scots from poorer backgrounds are 64% more likely to die of cancer, and we know too that general health outcomes for those in deprived areas, specifically Greater Glasgow region, are some of the worst in Europe, and I think these inequalities must be addressed. As well as tackling workforce planning, increasing patient safety in our hospitals requires us to ease tensions on the hospitals themselves, and that needs prevention, as has been mentioned before. The 2016 NHS audit report found that many NHS boards across the country struggled to achieve financial balance, and overall NHS Scotland failed to meet 7 out of 8 key performance targets. That's not exactly a picture of health, and it will only get worse if we don't continue to take action and continue to make improvements. Thank you.
Marie Todd, to be followed by Alison Johnson.
Thank you, Presiding Officer. I'm absolutely delighted to be able to participate in this debate. As many of you will know, I worked as a clinical pharmacist specialising in mental health until my election last May. I can honestly say that in my 20 years of working in hospital, nothing has come close to the effectiveness of the Scottish Patient Safety Programme in terms of change management. I hope that today's debate will provide reassurance to my Lib Dem colleagues that there is a step change occurring in mental health services already. The SPSP is about delivering reliable, safe care for every patient, every time, 24 hours a day, 7 days a week. As the Cabinet Secretary already mentioned, in mental health, the safety programme supported improvements at a ward level, where there have been examples of reductions of up to 70% in the number of patients who self-harm, 57% in the number of incidents in which physical restraints had to be used, and 78% in the number of incidents of physical violence in the ward. These figures are absolutely phenomenal, and they come from some of the most disturbed wards in Scotland. So what's so special about SPSP? The methodology empowers staff to identify what isn't working well, make changes, and while monitoring the impact of those changes by ongoing use of data collection. Data is incontrovertible, which makes it really powerful for instigating change. Let me tell you about some of the progress that's been made at the hospital I used to work at, New Craigs Hospital in Inverness. Before I left, we'd been using SPSP methodology for medicines reconciliation. It might seem simple, but the process of creating the most accurate list possible of all of the medications that a patient's actually taking and comparing that list against their records at transition points when errors are most likely to occur has dramatically reduced errors. The next focus of our attention was the use of as-required medication. This is where medication is used to alleviate symptoms of distress and agitation, so not a regular prescription. For some time now, coloured stickers were used in the notes to highlight the use of this type of medication. Red for intramuscular injections, yellow for oral drugs. The stickers prompted staff to record how well the patient responded, and the bright colours in the notes were a crude sort of visual cue as to how well the patient might be. An audit of these stickers at New Craigs highlighted that over 50% of the time when these drugs were being used, the patient only had a slight improvement or no improvement in symptoms. So discovering that an intervention doesn't work half of the time, of course, warrants a response. And the pilot team proposed seeing if alternatives to medication might be of more benefit to a patient. All of the staff, including my pharmacy colleagues, had training on decider skills. The training was excellent and techniques are popular with the staff and patients alike. And clearly, learning these skills, teaching these skills to patients, has the potential to have a much more lasting benefit than medication. So now, as well as the yellow-red sticker system, there's a green sticker which is used to record the score of the psychological intervention from both perspectives, from the nurse's perspective and the patient's perspective. And I hope that this example demonstrates the power of this incontrovertible data to drive change. The fundamental issue with SPSP is that it empowers the staff at the coalface. My colleagues are increasingly turning to this methodology as a standard approach to problem solving and process improvement. As I've mentioned before, this government's enabling all healthcare professionals to develop and take on new roles. In order to support GPs and other primary care colleagues, the pharmacists at New Craigs have all trained as prescribers and they're taking their skills from the hospital out into the community, and the SPSP methodology will be ingrained in this change to identify and improve any processes which aren't working well. So to sum up, let me finish by saying that Scotland is absolutely leading the way with the Scottish Patient Safety Programme. Our ambitious and comprehensive approach to improving safety and quality of care might have caught the interest of the rest of the world, but it's the results which have made it really impressive. Thank you.
Call Alison Johnson to be followed by Claire Hockey.
Thank you, Deputy Presiding Officer. The Government's motion today acknowledges the success of the Scottish Patient Safety Programme. It also acknowledges the significant challenges that face the NHS. Given the scale of those challenges, we must take stock of approaches which do work, learn from them, and build on opportunities to expand them. However, the amendments presented today all rightly address workforce shortages which undermine the efforts of our NHS staff to provide the best possible care. Staffing levels are essential to patient safety and demand is often outstripping supply. The latest ISD figures show that many patients are facing unacceptable waits for diagnostic tests and treatment. And I am worried that while our health service is delivering very high standards of safe care to most patients, many others are being left too long without the care they need. The Government points to its long-term strategy, but we also need urgent action to improve access to care for patients who need it today. We have been promised a new national workforce plan, but I am not wholly encouraged by recent signs like the modest uplift to student nurse numbers. An increase of 142 student nurses is not ambitious enough, not when 28% of nursing posts in the care home sector are vacant. And Bliss Scotland's report on our maternity and neonatal services found that many of our neonatal units don't have enough nurses in post and that most struggle to ensure that nurses get appropriate specialist training. And that training and support is essential. We know that when staff are well supported and their experience is valued, they can achieve fantastic results for patients. The Patient Safety Programme has delivered some of the best examples of improvements in our healthcare system, and that's because it gives staff the opportunity to drive change themselves, as we have heard. And learning from this approach can help make our hospitals and our community health services more attractive places to work in. Sometimes NHS targets are criticised for creating perverse incentives, contributing to a tick-box culture and putting processes, not patients, first. But this patient safety programme set ambitious goals, and it has surpassed many of them. Indeed, the Royal College of Nursing Scotland, in their briefing for us in November last year, said there have been real improvements in the way health services are delivered in Scotland over the last 10 years. For example, the patient safety programme. A 16% reduction in hospital mortality, an 18% reduction in stillbirth rates, a 21% reduction in mortality from sepsis. Colleagues have raised these, and these are clear and significant changes and improvements, all achieved by staff working together to review their practice, question their normal processes, and develop safer alternatives. This is brave work, and I wish to thank all of the staff involved in the pilots, collaboratives, and improvement projects across Scotland. And I'm very glad that the patient safety programme is now moving into care homes. It has set a target of reducing harm from pressure ulcers by 50% in hospitals and care homes by December this year. That will greatly improve quality of life for many people. We need to ensure high standards of safety as health and social care is integrated, and this is the kind of approach we need. I want to see the successes of the patient safety programme reach even further, not just to care homes, but to those who are cared for at home and in our communities. Very often people feel that a frail elderly relative would simply be safer in hospital, that that's the best place for them. They're more confident that risks will be minimised there. But we need to take the patient safety programme's rigorous approach to improving the safety of vulnerable people cared for at home too. Now, there are clear challenges there because at the moment, social care staff don't have much chance to lead improvements to care services. They often have to work in relative isolation, under pressure, with few opportunities for training and development. One strand of the patient safety programme is its highly regarded fellowship programme, which allows clinicians to develop their leadership skills, strengthen collaborations, and learn directly from international experts. It's crucial that we invest in our future clinical leaders. In the long term, we have to develop equivalent mentoring, training, and expert support for our social care staff. Back in our hospitals, however, there are concerns regarding the ability of consultants to teaching up-and-coming medical students, and this has implications for patient safety. And it leads to the perception that Scotland is a 9-to-1 country, and that's a reason cited by consultants who are not attracted to practice medicine here. And it impacts on their contribution to the NHS too. But one crucial aspect of the programme... You
should close now.
Thank you. A crucial aspect of the programme is that it encourages people to be open about failure. Today's debate has highlighted great successes, and we should be proud of the staff who led this challenging work, because they weren't just looking for good news stories, but examples of failure that others can learn from. Presiding Officer, I applaud all those who contributed to the patient safety programme and its outstanding achievements. Thank you.
Claire Hawkey, to be followed by Jeremy Balfour.
Thank you, Presiding Officer. And I would like to refer members to my registered interests. I am a registered mental health nurse. I am proud to say that Scotland's health services are again leading the world in innovation. And because of the commitment that this government has to this sector, we're rolling out new ways to deliver healthcare in the 21st century Scotland. The wider integration of health and social care, again spearheaded by this government, acknowledges that to care for individuals without looking at all of their needs can only get us so far. We recognise in Scotland that we need to have a holistic system to tackle problems that have multiple contributing factors, and the Scottish Patient Safety Programme recognises this. And I would argue that nowhere is this more in evidence than in the area of my own clinical practice, mental health services. When we look to treat the person rather than the condition, we take into account their own experience of their illness, their individual strengths, and what their recovery means to them. And this approach is especially relevant to those receiving treatment from mental health services, as those patients frequently experience unique challenges, the challenges that the SPSP tackles. It does this through 5 main work streams: safer medicine management, risk assessment, violence and restraint reduction, communication and strong leadership. The 5-pronged process works by placing the requirement on healthcare professionals to systematically gather information on these key areas and to tailor their care for the individual accordingly and based on evidence. To deliver this, the Patient Safety Climate Tool was created, ensuring patients' voices are heard when their care is being planned. This tool invites patients with mental illness to record their experiences of receiving treatment, from how they feel in a ward to how their medication is affecting them. And their experiences are recorded and the staff are committed to then acting on that feedback the patient gives them. For patients, this is an empowering experience, but it's more than that. This is an extremely effective system with its success borne out in the figures. There have been over 600 patient safety climate tools and 3,000 staff climate surveys completed in the past 4 years. These gather both the patients' and the staff's feedback too. That's a huge amount of real intelligence on patients' experiences and the experiences of staff on the wards. This is already having a demonstrable effect on care, with participating wards showing massive improvements. As my colleague Marie Todd already alluded to, there are reductions in restraint of up to 57%. There are reductions in the percentage of patients who self-harm of up to 70%. And there are reductions in the rates of violence of up to 78%. Those, presiding officer, are amazing figures that we can all support in this chamber. When violence drops to a quarter of existing levels, and when self-harm drops to less than a third, this is a massive improvement in the lives of real people, both patients and the healthcare professionals who look after them. And this presents a fantastic opportunity to improve mental health care nationwide and to share our learning internationally. These numbers should be applauded, and they are concrete evidence that using a human rights-centred approach in mental health care just simply works. Presiding officer, when we engage with patients, use their feedback and tailor their care and environment appropriately, everyone involved benefits. And when we empower healthcare workers to share their experiences, to learn from their patients and tailor their approach, we ensure that care is personal and that outcomes are improved for everyone. We are fortunate with a devolved NHS that we can seek to implement these holistic human rights-centred solutions to the specific problems that Scotland faces. And with mental health wards already experiencing the benefits, I look forward to this approach rolling out to more services across the country.
Thank you very much, Ms Haughey. I call Jeremy Balfour to be followed by Richard Lyle, and Mr Lyle will be the last speaker in the open debate.
Thank you, Deputy Presiding Officer. And can I declare an interest that I have a number of family members who work in the NHS. The Scottish Patient Safety Programme was launched in January 2008, a 5-year national programme to reduce mortality and adverse events in acute hospital settings. Undoubtedly, there have been successes. Deaths cut by 15%, adverse incidents by 30% over the last 5 years. The most recent phase of work was completed in March 2016, and again, reductions in harm were down, which can only be welcomed by everyone. The care provided by NHS staff is fantastic. We all agree on that. And just because sometimes we critique or comment on Scottish Government policy does not mean that we are attacking frontline staff. And I think it is unhelpful sometimes for the government members to keep saying we're attacking frontline staff, when in fact we're pointing out what a good job they are doing in very difficult circumstances. Absolutely.
I thank
Claire
Mr
Haughey,
Balfour.
sorry.
Yeah. I thank Mr Balfour for taking that intervention. Perhaps him and his colleagues might then reflect on some of the language that they use in this chamber when they are describing the NHS, and they use emotive language like crisis and the effect that that does have on the staff that are working in the NHS.
Jeremy Balfour.
It's nothing to do with the frontline staff. It's all to do with this government and its lack of action. The SPSP has definitely helped to create a safer culture by staffing levels play an essential part in patient safety. And currently across a range of clinical specialities, the NHS is facing a severe workforce and staffing issue. And if we look at what is coming up in the next few years, it is likely that this is only going to get worse. A Freedom of Information request made by the Scottish Conservatives earlier this year revealed that dozens of adverse events are recorded every day in dementia wards of Scotland's hospitals. Over 160,000 such incidents have occurred in the past 6 years. An under-pressure health service attempt to deal with an ageing population, with incidents ranging from falls to assaults on staff to self-harm and patients leaving facilities. Much more seriously, bosses at NHS Greater Glasgow and Clyde said adverse events had resulted in the death of 49 patients since 2011. Patients in dementia wards are among the most vulnerable in our hospitals and deserve the best possible care for their sake and for the comfort of family members. And there's no question that wards dealing with dementia patients are in very challenging places to work. In such environments, many of those adverse incidents will have been unavoidable. But it's a credit again to frontline staff that they deal with these day in, day out. But patients in these wards and their families will be extremely worried at the sheer scale of these flashpoints. There are a significant number of incidents which were put down to staffing shortages or a lack of adequate resources and training. And again, that is not frontline services' fault, it is Scottish Government's fault. We need to see a plan to make sure our staff and hospitals are equipped for all the future challenges they face. While SPS is playing an important part in improving safety and keeping patients safe, we need to make sure our staff and hospitals are equipped for the future challenges they face. Thank you.
Thank you very much. Call Richard Lyle, last speaker, then we move to closing speeches, please.
Thank you, Presiding Officer. I'm delighted to be contributing to this debate on the Scottish Patient Safety Programme as a member of the Parliament's Health and Sport Committee. Scottish Patient Safety Programme is the first world-leading system of its kind to be implemented on a national basis. Focused on advancing the safety and reliability of healthcare, the Scottish Patient Safety Programme includes safety improvement programmes for acute adult healthcare-associated infections, maternity and children, medicines, mental health and primary care. The Scottish Patient Safety Programme is an international benchmark for safe care. The programme, as I believe, demonstrates a key relationship between the Scottish Government, the NHS Scotland, towards a shared desire to provide safe care and reduce harm, as well as achieving sustainable quality healthcare for everyone throughout Scotland. In particular, Healthcare Improvement Scotland has partnered with the NHS to achieve the goals set out by SPSP to help NHS Scotland to deliver high-quality, evidence-based, safe, effective, personal-centred care, to scrutinise services to provide public assurance about the quality and safety of that care. The idea of the evidence-based care is reliant on close, personal, hands-on staff throughout the NHS in a variety of care settings all over the country. Their attentiveness to each individual patient is what has allowed for continued reliability and improvement of routine healthcare systems and processes. The impressive work demonstrated by the NHS Scotland staff has progressed since 2008, despite demands raised by an ageing population, in addition to integrating health and social care services. Since 2008 implementation, the Scottish Patient Safety Programme has seen improvements in healthcare across all individual safety improvement programmes. For instance, the Safety Improvement Programme for Mental Health has seen an increased number of wards and units showing improvements in rates of violence and restraint. From 2008 until now, there has been a reduction of up to 64% of patient restraint, a 75% in reduction for patients who self-harm, and up to 80% reduction in rates of violence. In 2012, the acute adult programme has done so well that the Cabinet Secretary for Health and Wellbeing expanded its aims on top of its primary responsibilities, such as building capacity and capability within clinical and non-clinical roles. These new aims were to further reduce mortality in Scotland's acute hospitals and to further reduce harm experienced by patients in Scotland's acute hospitals, which has been achieved throughout continuous improvement. The groundbreaking work that the Scottish Patient Safety Programme has achieved is unique to Scotland and the healthcare programmes internationally. Its aim to reduce Scotland's mortality rates in a safe and effective way has been incredibly successful thus far. In upcoming years, NHS Scotland and programmes like Healthcare Improvement Scotland will face challenges concerning the well-being of Scots. However, the innovation improvement approaches the Scottish Patient Safety Programme implements will make these challenges surmountable. Once again, this initiative is a perfect demonstrator of an incredible service that is the National Health Service in Scotland. I'm proud that we here in Scotland not only continue to protect our NHS, delivering world-leading healthcare, but also that we are the pioneers of innovative approaches such as SPSP. I once again, with any health debate, wish to pay tribute to all who work in our NHS. In closing, I previously worked as a part-time out-of-hours driver for doctors in NHS 24. I've personally seen myself the excellent work done by all A&E departments in Lanarkshire. We do have one of the best health services in the world. Since coming to this place in 2011, I've seen increases in health spending going up tremendously. Yes, there is more to do, but let's stop kicking the political health football. We have seriously got to look what we're doing, what we're providing, how we can improve it, and how we will support our health providers. And I, for one, have to say our Cabinet Secretary, as she, I know, is totally committed to her brief, and I thank her for it.
Thank you very much, Mr Lyle. We have one culprit not in for the closing speeches, though. I think Anas Sarwar is holding his breath. There might have been summing up at one point for Labour. And undoubtedly the SNP whip will let Fulton McGregor know that it'd be good if he'd come in just to let us have his company in summing up when he's been in a debate. All right, we move to the closing speeches. I call Alec Cole-Hamilton, please, to close for Liberal Democrats. 5 minutes, please, Mr Cole-Hamilton.
Thank you, Deputy Presiding Officer. We've had an excellent debate this afternoon. I think there is a lot of common ground in terms of the recognition and support for the work of the Patient Safety Programme, wonderfully delineated in the excellent speech by Richard Lyle, who laid out in granular detail the successes and the huge advances in terms of patient safety that the programme has delivered. I reflect on the fact that Donald Cameron mentioned in his opening remarks that the opposition amendments are very, very similar today, and that was entirely uncoordinated in respect of workforce planning. It shows the depth of political concern on this matter. While it feels like Donald Cameron and Anas Sarwar and I have turned up at the same party in the same frock again, it demonstrates the significance attached by parties across this chamber to the staffing crisis in our NHS. And it was echoed very eloquently by Alison Johnson in terms of the Green Party perspective as well. And we have heard it time and time again. Staff shortage is having a material impact on patient safety in our NHS and in our social care workforce, either because appropriate clinicians are not available, or if they are worked to the point of burnout. And Brian Whittle, I think, made the very excellent points in his speech of the impact that this can have on staff safety, particularly in respect of the staff absence it can lead to, which in turn exacerbate the wider problem. Now, Fulton McGregor did recognise the importance of having a full complement of staff, but did not pay heed to where we get them and how we address this crisis in our NHS. The Cabinet Secretary, I'd like to thank her for this, because I think in her opening remarks she opened an avenue of this discussion which I hadn't really considered, and that was the reference to the very excellent report published by the Chief Medical Officer, Dr. Catherine Calderwood, on realistic medicine. Claire Hawhey rightly points out to the need for rights-based patient planning, and for me, nothing says that finer than the treaty espoused in realistic medicine. And as a Liberal, this speaks to my own core values, that ultimately patients, when equipped with all of the information around their situation, will make decisions that are right for them and that will sometimes surprise their clinicians and choose less life-extending interventions in favour of spending their last few days in the comfort and dignity of their family home. I hope that we have opportunities to unpack further the intellectual arguments in this chamber over quantity versus quality of life and the harm that too much focus on the former can do. Donald Cameron said that this unites the chamber, and that the programme is internationally recognised, and it really is. He outlined some of the context against which it was originally brought in and the measurable impact it has had, not just on reducing harm, but in the measurement of human lives saved and reduction of preventable deaths, a theme that was then picked up by Jeremy Balfour. Anas Sarwar rightly pointed out and referenced the spectre of major service redesign and the potential impact that this might have on patient safety, and should that not receive the full scrutiny of Parliament as we have voted for it to do so before. Now, Elaine Smith also made some very excellent points about access to medicine and underscored with harrowing examples the blockage currently preventing patient flow through our health system, especially around the hundreds and thousands of bed days lost to delayed discharge. And so much of what Elaine Smith said in her excellent contribution was particularly around the needs of older people. And I very much hope that the Scottish Government will respond to my call for a national falls strategy in their summation this afternoon, because this was a theme I think touched on also by Jeremy Balfour in his contribution about the needs of dementia patients, dementia wards, and the distance we still have to travel. I mentioned particularly the remarks of Marie Todd, who very kindly referenced our amendment, but said there was a step change happening in mental health in this country. I take issue with that. And she and I were attendees at the same mental health conference last week, where it was very clear that we are far from a step change in mental health. We are still lacking talking therapists in every GP surgery in the country, something that the Liberal Democrats will not cease from calling for, because that is the only way of delivering on the Scottish Alliance for Mental Health call for asking once and getting help fast. Same too in terms of investment in CAMHS and other sectors within the mental health area. That said, I do think we are very well served in this chamber to have the expert professional knowledge of members like Emma Harper, Claire Hawhey and Marie Todd. And in the spirit of cross-party consensus, I look forward to hearing their contributions and following their guidance in this area. And they are right, the patient safety programme is something that is world-leading. It is something of which we should all be justifiably proud. And I believe that the opposition amendments today seek not to denigrate it, but to enhance it. Thank you.
Thank you very much. I call on Colin Smith to close for Labour. 5 minutes, Mr Smith.
Thank you, Deputy Presiding Officer. During this afternoon's debate, members have all acknowledged the positive impact the Scottish Patient Safety Programme has had since its establishment in 2008, and Richard Lell in particular summarised the list of successes well. The Cabinet Secretary, amongst other things, highlighted the success of the surgical safety checklist, where Scotland is leading the way, and that is something we should all be very proud of. And she stressed the fact that the encouraging outcomes of the programme has led to expanding recently to include paediatric and neonatal care, maternity, mental health services and primary care, increasing the positive impact of the programme on our health and well-being, such as improvements in mortality rates stressed by the Cabinet Secretary and by Donald Cameron. Alison Johnson also rightly made the valid point that the programme had surpassed its initial goals. A number of members made important constructive suggestions of further improvements, however, such as Brian Whittle's point about consistency in the measurement of adverse incidents, and Alex Cole-Hamilton raised the issue of a national fall strategy. And it is important that we do build on the success of the programme. We know that the overall trend for premature deaths is one of steady improvement, and life expectancy itself in Scotland has risen from 64 years for men and 69 for women when the NHS was established, to 77 for men and 81 years for women today. But that only paints part of the picture. Premature death is still much more common in Scotland than it is in England and Wales. Elaine Smith highlighted that there are huge disparities between deprived and more affluent communities. As the Health and Sport Committee's report on health inequalities said in 2015, a boy born today in Lenzie, East Dunbartonshire, can expect to live until he's 82, yet a boy born only 8 miles away in Calton, in the east end of Glasgow, has a life expectancy as low as 54 years, a difference of 28 years, or almost half as long again as his whole life. The solutions to this appalling fact cannot be tucked away in patient safety or indeed any part of the National Health Service, or written off as a problem of individual behaviour. If we want to tackle health inequality, we need to be more serious about tackling wealth inequality. Now, I think it's fair to say that every member today has rightly stressed the often heroic efforts of our health and social care workforce and the outstanding contribution they make to our health and well-being. As Anas Sarwar said, there would be no patient safety programme without the work of our healthcare staff. But the truth is, there isn't enough of them to keep doing what we need our NHS to do. It's not good enough for some SNP speakers to keep saying we have more doctors and more nurses, but fail to acknowledge that staffing levels are simply not keeping up with growing demand. We need an honest debate about the future funding and staffing of the health and social care sectors. We all accept that we have an ageing population and more people with complex care needs. However, despite a growing demand for services, local health boards are still being hit by significant health savings targets, £1 billion over the next 4 years, and that cannot be achieved without impacting on services. And those cuts come at a time when the NHS is struggling to recruit and retain staff, which is exacerbated by the number of unfilled trainee and specialist posts. 1 in 4 of our GP practices reports a vacancy, and we have a ticking time bomb of GPs queuing up to retire. The Royal College of General Practitioners has predicted that by 2020, Scotland will have a shortfall of 830 GPs, which will be needed just to return to 2009 levels. It's not just in GP numbers that we have that crisis, and yes, it is a crisis. There are more than 350 consultant vacancies, nearly half of which have been vacant for more than 6 months. There are 2,500 nursing and midwifery vacancies, including more than 300 unfilled mental health nurse posts. The consequence of the failure of the government's workforce planning is not only high vacancy rates and training posts going unfilled across the NHS, is an increase in the burdens on existing medical staff, which are adding to an already unsustainable workload. As Dr Peter Benny, the chair of the British Medical Association in Scotland, has warned, our NHS workforce is stretched pretty much to breaking point. Now, Emma Harper shared her own invaluable experience, but she also touched on the issue of staff morale. Well, let's look at what really damages staff morale. The Royal College of Nursing surveyed their members and revealed that 90% had said their workload has got worse. Now, that's what damages staff morale. NHS Scotland's own staff survey showed that only a third of NHS staff feel there are enough staff to do their job properly. That's what damages staff morale. So, Deputy Presiding Officer, in concluding, very briefly,
I had this sixth sense that Ms Harper was going to rise to that, and you didn't let me down.
Thank you, Presiding Officer. The reason about staff morale, it doesn't matter what a nurse does in a shift. She will always, or he will always feel they could do more. So the surveys, I think, are quite sometimes maybe not the best way to portray it, and I'm sure Mr Anas Sarwar is helping you with a response to that right now.
Give your time back, Mr Smith.
Well, I hope that what Emma Harper will do is actually read the surveys that have been published by the Royal College of Nursing. 90% said their workload has got worse. NHS Scotland's own staff survey said that only a third of staff felt there were enough staff to do their job properly. What impacts on staff is a shortage of staff, the failure of proper workforce planning, and the fact we're asking our staff to do too much with too few of them. And it's about time this government started to acknowledge that was a problem instead of burying their head in the sand and pretending we had enough nurses and doctors. So, Deputy Presiding Officer, in concluding today, Labour will back the wording of the government's motion and will show our support for the patient safety programme. But we'll also back our hard-pressed nurses, doctors and all health and social care staff by backing the amendments and showing support for a staff team that's overstretched and under-resourced by this government.
Thank you very much. Call Miles Briggs to close for Conservative. 7 minutes, please, Mr Briggs.
Thank you, Deputy Presiding Officer, and I'm pleased to close today's debate for the Scottish Conservatives. The debate has been useful and there's been much consensus, well, perhaps not amongst the SNP and Labour members, but all of us can, I believe, support the aim of the Patient Safety Programme to reduce mortality and adverse events in all NHS settings. Whilst we recognise that the Scottish Government has made progress, Donald Cameron, I think, is right to highlight the importance of staffing levels when it comes to patient safety. And other members have raised legitimate issues around specific services, including maternity and neonatal care and paediatrics. And particularly, I pay tribute to the points raised by my colleague Brian Whittle and Alison Johnson, who highlighted the key issues around midwife recruitment concerns, which many of us are having told to us by constituents. The care of the elderly in hospitals has been mentioned by a number of members and is an issue I'm particularly concerned about. A recent Freedom of Information request showed that there are typically at least 3,000 examples each year of elderly patients in hospitals in my own region of NHS Lothian suffering falls in elderly care and dementia wards, and that a significant proportion of these falls are causing moderate or major harm to patients. We need to ensure that all these measures are put in place in elderly care wards to ensure that falls are minimised, including having enough staff on duty at all times to care for those monitoring patients. As well as causing bone breakages and fractures and affecting mobility, falls can destroy the confidence of our older people and make them less likely to undertake the physical exercise so important to maintaining the overall health of these individuals. Alex Cole-Hamilton spoke about preventing these falls, and I totally agree with what he had to say. The cost to the NHS of treating falls is also significant. An investment in fall prevention can save really under pressure NHS resources, and we need to look at this. Technology will play a huge role in this, and just last week I visited a company called Snap40, who are the doctor at your side. Now, I welcome the fact that they will be undertaking 2 pilots in NHS Scotland, but the continuous monitoring device which they've developed can automatically identify the warning signs of health deterioration. And I think technology like that is something we need to lead here in Scotland. As my party's mental health spokesman, I welcome the progress that was identified in the Scottish Patient Safety Programme Mental Health Phase Report from last November, which covered 2012 to 2016 and has influenced the development of the mental health safety principles. As the Cabinet Secretary has said, there is some very positive data in this report, including examples of reductions in restraint of up to 57%, a reduction in the percentage of patients who self-harm of up to 70%, and a reduction in the rates of violence of up to 78%. Mary Todd also said, that, and I support her on this, that we should pay tribute to all those who work in our mental health services and who have helped to achieve these important and significant progress in our mental health services. While the work that has been undertaken focuses on our acute mental health service wards, we look forward to the rollout of similar approaches to inpatient mental health services across Scotland. This will be challenging, but it is important, and I hope the Scottish Government will really make sure this is progressed within the mental health strategy. I also welcome the fact that the SPSP mental health work will also support the work of Equally Fit in reducing physical health inequalities for those suffering from severe mental illness, along with the support in Mind Scotland, CME and Bipolar Scotland. The need for the patient safety programme to be supported at all levels of our healthcare provision across services is vital, from NHS board level down to local teams within hospitals and GP practices and community pharmacies clearly have a role to play in this, and I hope that's something which will also be taken forward by the Scottish Government. It's important for all parts of our health service and for NHS workers to share the aims of the safety programme, to share relevant information and best practice and work collaboratively. And as Elaine Smith said, this is important also to ensuring that NHS staff are adequately supported to be able to implement the programme and encourage further development and training. I think it's also worth reflecting that many patients in the acute hospital setting can find this an incredibly disorientating environment and experience. On a recent trip to the Queen Elizabeth Hospital in Glasgow, the Health and Sport Committee saw What Matters to You boards within the Specialist Dementia Care Unit, or at least one room which we actually visited. These patient information boards provide the things which are important to individuals and are incorporated in the care, planning and delivery process. The What Matters to You boards at a patient bedside display information at a glance and actually are part of a conversation with the patient and their family. This has helped to personalise care, providing quick prompts to relieve distress for some patients and act as an aid for non-permanent members of the care team on important issues to facilitate communication with patients, with information being updated as and when changes occur for that individual. And I think this is something I was particularly impressed with and hope will be rolled out as a national standard across Scotland. I also wanted to highlight the issue during this debate of hearing aids and reading glasses being lost. One of the issues which have struck me as a new MSP is a number of people who contact me to say that loved ones have had incidences where their hearing aids and reading glasses have been lost when they maybe go between care home setting and hospital appointments. And I think that's something we need to look at, because I know certainly in these cases it's really upset individuals and actually added to the deterioration of their health. And it's something I hope the Scottish Government will also really consider. Claire Hockey and Richard Lyle used this debate to actually talk about opposition members talking down our health service. And I have to say, that couldn't be further from the truth. I meet with NHS staff so often, and see how often they are under... I don't have time. We've heard enough,
The members
I think,
in
today.
this last minute.
But to see these members of our health service under pressure, we have the right, and we have them in mind when we come to this chamber with these debates, to actually have to be their voice in this Parliament. Because when the Royal College of GPs and RCN tell us that there is a crisis in this service, we have a duty to actually highlight that to this Parliament. And we make no apologies for doing that, because we support our NHS staff 100%. And as I've said in this chamber before, our NHS staff, the NHS does not depend on the SNP government. It depends on those who work in our health service day in, day out. And we need to make sure that voice is heard. To conclude, Deputy Presiding Officer, Scottish Conservatives welcome today's debate and support the aims of the Scottish Patient Safety Programme to minimise adverse events and avoidable harm in the health service. We recognise that good progress has been made, but there's still a lot of important improvements to put in place to ensure that patient safety outcomes are as good as they possibly can be. We look forward to the Scottish Government on both providing the national leadership required to drive forward this programme and the funding to support all parts of our NHS to allow this to be put and to deliver best practice.
Thank you. I call Aileen Campbell to close for the Government. Minister, up to 4:59, please.
Thank you, Presiding Officer. And I'm pleased to close today's debate because while we are not blind to the challenges, it is right we pause to recognise the phenomenal improvements brought about by the Scottish Public Safety Programme and Marie Todd and Emma Harper's professional analysis of this important and the impact of this important approach in their contributions today is compelling, because in Scotland we have, as the Cabinet Secretary outlined, 24% reduction in surgical mortality, 21% reduction in sepsis mortality, and 18% reduction in stillbirths, 93% reduction in healthcare associated infections, and a 78% reduction in ventilator associated pneumonia. And I welcome the largely consensual comments from members who have chosen to be constructive in their participation of today's debates. I just wanted to single out Alec Cole-Hamilton, who I think made a very informed contribution. I recognise his continued interest in making improvements in mental health. Likewise, Miles Briggs as well in his summary. Points that I know will be taken on board by my colleague Maureen Watt, who announced recently the MCN on perinatal mental health, and which will be a priority in terms of the implementation of the recommendations set out by Jane Grant and the Best Start report. And while there are challenges around delayed discharge that Alec Cole-Hamilton, I think, and others did raise, there has been an 11% reduction on bed days lost since 2011. And regarding falls, again, another point raised by Alec Cole-Hamilton and his comments that falls were more feared by the elderly than crime. We are making progress on this, and efforts across hospitals and care homes are taking action. For example, NHS Grampian has reduced falls by 14%, and there has been, more generally, a reduction in falls right across the country. But he and Miles Briggs and others are right that we need to continue to focus on that, which is why in my portfolio, which also includes sport, it's also imperative that we do what we can to get our older population more active so that they have that resilience to cope with the falls if they happen to them in later life. And again, I'm happy to continue that dialogue with Miles Briggs and Alec Cole-Hamilton and perhaps Elaine Smith, if that's
Elaine
what
Smith.
she wants to raise.
Thank you, Presiding Officer. Thank the Minister for taking the intervention. But in keeping older people more active, would you agree with me that up to 24 weeks for operations such as hip replacements is not acceptable?
Minister.
We do have capacity in the Golden Jubilee. I understand the points that she raises around NHS Lanarkshire. That's a point that we continue to engage with NHS Lanarkshire on to support and try and make better progress on some of those issues. But I think the point that she makes is relevant. However, we are making sure that there's capacity in other hospitals to try and cope with some of that demand. But it's an issue that we continue to work through, and we'll continue to engage with her on those points in that local setting. The debate, I want to look ahead, though, however, to what's next for the Scottish Patient Safety Programme. And the teams in the Scottish Patient Safety Programme are ambitious. They have reviewed the varied work and many achievements to date. Looking forward, the programme will have a much wider focus on the overall patient journey. And that will ensure that sick patients are identified appropriately and timely, that they receive their medicines safely and effectively, and that they move through their healthcare journey as safely as possible. During 2016, the content and the delivery methods for the future programme were reviewed. And this identified 3 core themes under which future work will be planned: prevention, recognition and response to deterioration, medicines and system enablers for safety. A greater focus will be placed on designing improvement activity across pathways of care, with a focus on NHS boards and partnerships setting their own priorities and outcomes to be achieved to meet their own local needs. And whilst improvements continue to take place in healthcare settings, improvement methodologies from the programme are also being applied across the public sector in Scotland, whether in education, justice or beyond. And we are spreading our improvement approach beyond the boundaries of health and social care. I think points touched on by Alison Johnson. The Children and Young People Improvement Collaborative is central to our work to make Scotland the best place in the world to grow up. It joins up the Early Years Collaborative and the Raising Attainment for All programme to use quality improvement approaches to deliver improvements throughout a child and young person's journey to support positive experiences in the early years and educational attainments. I think I might have to have an improvement approach to my own voice at this moment. It's just deteriorating
You can pause for a sip of water, we'll understand.
Our Health and Social Care Delivery Plan, published on the 19th of December, sets out how we will further enhance health and social care services. Through this, the people of Scotland can expect to live longer, healthier lives at home or in a homely setting. And we'll have a health and social care system that is fully integrated, focuses on prevention, anticipation and self-support management. It will make day case treatment the norm, where hospital treatment is required and cannot be provided in a community setting. It focuses on care being provided to the highest standards of quality and safety, whatever the setting, with the person at the centre of all the decisions, and ensures people get back to their home or community environment as soon as appropriate, with minimal risk of readmission.
Could members please, the Minister's struggling womanfully on through a bad cold and you're all chittering and chattering away. So stop it.
Thank you, Presiding Officer, for your sympathy. A very matronly approach to this. So, in its 9th year, the Scottish Patient Safety Programme continues to grow, to mature and to develop to meet these new challenges in the new integrated environment. Increasingly, the emphasis will be on supporting NHS boards and health and care social partnerships to identify their local priorities, and the Scottish Patient Safety Programme will act to tailor any improvement support required to meet those local priorities. Turning, however, though, to some further points raised by members, many members raised the issue of the workforce. And while it is absolutely right to hold government to account, and we would never deny any opposition member to do that, we must also, though, I think, be mindful of the words of Emma Harper and Claire Hawkey, who made the point about the impact of consistent negativity on the morale of our NHS staff, who work daily on our behalf to help others. Because this government is committed to supporting and developing our workforce. Staffing has increased. Qualified nurses and midwives are up by 4.9%. The Cabinet Secretary announced a 4.7% increase in intake to pre-registration nursing and midwifery programmes for 2017-18, meaning 151 extra places, and that's the 5th successive rise and equates to 3,360 new places. We've committed to retaining the nurse student bursary, unlike in the rest of the UK.
Anna Sarwar.
Thank the Minister for taking intervention purely out of solidarity. I thought I'd give her a chance to also get a sip of water as she's struggling today. Can she address the point directly made by Dr Peter Benny, that if it's not, the workforce crisis is not addressed, it will lead to personal breakdown and then system breakdown?
Yes, sir.
Force plan that's coming out, and again I would notice what Anna Sarwar announced at the weekend. Again, he's playing catch up with action this government is already taken, and I think he should take cognizance of that fact and the improvements that we have. And he puts his hand up 10 years. The fact is 10 years would have meant Monklands A&E would have been shut, 10 years closed would have been Ayr A&E. So actually I think the record that we have today is a positive one, a good one, and will continue to govern effectively for our NHS. And as part of this support to the workforce, Claire Hawkey also made an important point about empowerment, and the improvement approach empowers practitioners. The programme and the CMO's broadening of realistic medicine also means we empower the patient to be in control of their own care. But we know there are challenges, which is why we are developing a workforce plan, and will continue to engage with other opposition members on the strategic future of the NHS where their voices are constructive. Bruce Crawford, however, did intervene on Anna Starwer's contribution, or I think he described it as chuntering, as he described it, and asked a very simple question as to why they did not commit to more funding in their manifestos for the NHS. Because, presiding officer, it was this party, the SNP, that pledged the most financial support for the NHS, and it's this government that will deliver, has and will deliver on it. And no matter how much the opposition don't like to hear it, unfortunately, that uncomfortable truth for Anna Starwer is one that this government will continue to repeat and keep repeating and continue to deliver for our NHS. Miles Briggs also mentioned, however, what matters to you day, and I was desperately trying to find in my notes about when the next one will be. I'll get back to him on it because of the success that happened from last year. But to conclude, presiding officer, I want to again quote Don Berwick, who said, "In my opinion, Scotland should be extremely proud of what it's done in the improvement of healthcare and extremely excited about what it can do now with ambition to make Scotland the healthiest country in the world. It may be the leading example in the world." On that point, I'll conclude, and I think we should all, though, be grateful to the impact and effort and the dedication of our committed NHS staff for allowing us to be able to showcase Scotland's NHS on that global stage.
Thank you. That concludes our debate on the Scottish Patient Safety Programme. The next item of business is consideration of motion 3924 in the name of Michael Matheson on the UK Criminal Finances Bill. And I call on Michael Matheson to move the motion. Thank you. The next item of business is consideration of 3 Parliamentary Bureau motions. I call on Joe Fitzpatrick to move motions 4332, 4333 and 4335 on the approval of SSIs.
Moved on block.
Thank you. And there are 6 questions at decision time today. The first question is that Amendment 4324.1 in the name of Donald Cameron, which seeks to amend motion 4324 in the name of Shona Robertson on the Scottish Patient Safety Programme be agreed. Are we all agreed? Yes. We're all agreed. The next question is that Amendment 4324.2 in the name of Anas Sarwar, which seeks to amend the motion in the name of Shona Robertson be agreed. Are we all agreed? No. We're not agreed. We'll move to a vote and members may cast their votes now. Vote on Amendment 4324.2 in the name of Anas Sarwar is yes 62, no 61. There were no abstentions. The amendment is therefore agreed. The next question is that Amendment 4324.3 in the name of Alex Cole-Hamilton, which seeks to amend the motion in the name of Shona Robertson, be agreed. Are we all agreed? No. We're not agreed. We'll move to a vote and members may cast their votes now. The result of the vote on Amendment 4324.3 in the name of Alex Cole-Hamilton is yes 62, no 61. There were no abstentions. The amendment is therefore agreed. The next question is that motion 4324 in the name of Shona Robertson as amended on the Scottish Patient Safety Programme be agreed. Are we all agreed? Yes. We're not agreed. We'll move to a vote and members may cast their votes now. The result of the vote on motion 4324 in the name of Shona Robertson as amended is yes 62, no 61. There were no abstentions. The motion as amended is therefore agreed. The next question is that legislative consent motion 3924 in the name of Michael Matheson on the Criminal Finances Bill be agreed. Are we all agreed? Thank you. And can I put a single question on Parliamentary Bureau motions 4332, 4333 and 4335? If any member objects to me doing so, please say so now. No. So the question is therefore that we agree motions 4332, 4333 and 4335 in the name of Joe Fitzpatrick. Are we all agreed? Yes. We are all agreed. And that concludes decision time. I close this meeting of Parliament.